Thank you for the introduction, and it's a great pleasure to be here. The topic of phenotypes, syndromic HS, and comorbidity, I just briefly touch base on each, and they are my conflict of interest. HS is a heterogeneous disease. We all see that it has many types. Does these phenotypes tell us that there are multiple pathways involved, and how this classification and knowing the phenotypes can affect our approach to HS, and does it affect prognosis and response to treatment? We don't know yet. In literature, in the past, classic or typical HS was described as deep-seated nodules, scars, hypertrophic scars, or rope-like scars in intertriginous area of the body. But we have atypical HS too. Patients coming to us that they present HS-like lesions in area like around neck, behind ear, or they present from the beginning like a cribriform scar, and they are not the typical cases that we see every day. The first attempt to actually put the phenotype together was from a French group. They look at 648 patients, cross-sectional, and they divided the patients in 3 groups. It was published in JID in 2013, and latent class 1 or axillary mammary was almost half of the cases with involvement of breast and armpit, hypertrophic scar, usually females and overweight. That's what we commonly see in the clinic. And then this is the typical HS in the previous literature. And latent class 2 or follicular HS is usually they are men, smoker, greater severity of the disease, earlier onset, longer duration, more follicular lesion associated with pilonidal sinus, comedone, and acne that we said. And these are, this is fit in the atypical category. And latent class 3, follicular papule, folliculitis, lower BMI, smoker, less severity, again, male patients. But there are many types of HS that they don't fit in these 3 categories. Then in 2015, Dr. Van der Zee and Dr. Yemek introduced another classification or phenotypes of HS in their paper as 6 phenotypes. Regular type, which is the classic HS, involvement of axilla, and then scarring folliculitis type, that even this patient might have classic HS, but they have deep, they have lesions, follicular lesions that heals with this distinct atrophic scar, usually female, overweight, and over buttock is a common place that you see that. Frictional Frankel type is the type that you see fruncle and follicles in area of friction. It's almost like a pathergy that you see lesions in the area that is more friction. And these the 2 latter are mainly fit in the atypical category, and 3 more atypical conglobata type that patients are usually male, they have acne conglobata, and then they have more severe disease, they are not overweight, and this category. And then we have syndromic HS, usually with acne, PG, that we talk about it, and ectopic HS in area like a stump is from amputation and in different areas. Then in 2016, another group from China look at the genotype-phenotype correlation, and they look at the group of HS that they have been connected to a gene of gamma secretase mutation or necastrin mutation. We know that just a small category of HS patients have genetic link, but does the morphology different in this group? And they look at more than 50 cases, and mean age was 20, mainly males with more severe disease, involvement of neck and back, and with folliculitis, comedone, papule. In addition, relation to classic HS, almost the same as latent class 2, what has been described as follicular HS. And more recently, in 2017, they look at BMI as a factor to divide the phenotype in patients with HS. Does BMI could be a factor that we predict treatment or separate phenotype of HS patients? The role of BMI, when look at the group of patients, BMI less than 25 and more than 35, and overall conclusion was that in low BMI, we have three groups, either infrequent eruption, pubic and genital involvement, axillary and mammary, but high BMI usually are associated with more severe and extensive disease. I want to show you in the previous picture, the picture in the right, the blue, is our patient with very low BMI. She's thin, but she has the most severe disease. Then the conclusion at the end is still we are not there. We don't have a consensus in phenotype classification of HS, and what does this predict our response to treatment? Not yet there. When we look at syndromic HS, the syndromes that have been described with HS can be put in three main categories. Syndromes that are associated with a structural defect of pilosebaceous unit, genetic defect, or autoinflammatory. And all of this reported can fit in one of them or overlap between them. When we look at syndromes that are associated with autoinflammation, pyoderma gangrenosum and acne are the two main components of this syndrome. When we have pyoderma gangrenosum and acne and pyogenic arthritis, the syndrome that was described is PAPA syndrome. More than 40 cases have been described. Mainly IL-1 pathway is involved, and response for treatment in this group is different, and also there is a genetic link. But when PG is associated with acne and HS, then it's PASH syndrome, that not just only in 5 cases, some change in gene has been reported, but is not associated with the same gene. And then when we have this with pyogenic arthritis, it has been described as PAPASH syndrome. That is, again, the gene has been recognized in this group. It has been described with PG acne and colitis, PG acne and PASH syndrome and psoriatic arthritis with no link to gene, and also with ankylosing spondylitis, and also recently cases of familiar Mediterranean fever and before SAPHO syndrome that has been linked between HS in autoinflammatory base. Acne is the main component of syndromic HS, usually is a severe nodulocystic acne, and they present as large nodules in back and chest area. The other component is PG, pyoderma gangrenosum, that in the base of PAPA syndrome or PASH, even though it's limited cases, they have been mainly lower extremity, and they have pathergy, and interestingly, the PG respond to treatment well. In PASH syndrome, this is a case that from our center that we presented with HS, but on thigh, he had a lesion of pyoderma gangrenosum. Usually PASH syndrome more common in male, mean age 37, and they have acne. They don't need to have all components at the same time. Acne conglobata or acne might precede the presentation of HS, and PG might appear at the end, and PG respond well to treatment. When we come to syndromic HS with follicular plugging or a structural defect, we have a list of keratinization disorder or genetic disorder that have been described with HS. Follicular occlusion syndrome is one of them that we see more. It's acne, combination of acne conglobata, dissecting cellulitis of the scalp, pilonidal sinus, and mean age 33, and predominantly male and with Afro-American preponderance. What recently has been a few cases of that is another syndrome, Dowling-Degoes syndrome, has been reported with HS, that is loss of function in keratin 5. And I think the importance of all of these syndromes is help us the different part of pathophysiology of HS and components that are involved. And in this case, mainly is follicular hyperkeratosis is in pathology indwelling the ghost disease. And they have a symmetrical reticular pigmentation of folds and perioral acneiform scar and also HS. Keith syndrome is another syndrome with mutation in connexin 26 and connexin 30 genes that has been reported in link with HS. And also Sapho syndrome, which is more autoinflammatory, and they have synovitis, hyperostosis, and osteitis, and neutrophilic dermatosis, including HS. In terms of association, this is from Michel paper that HS is a systemic disease. The link to metabolic disease have been reported in many studies. Recently, a paper looking at, I think from Jocelyn, looking at a large database of diabetes and HS that showed that 10% of patients with HS, they have diabetes, psychological disorder with described in the next lecture, rheumatology, they have spondyloarthropathy, gastrology, IBD, and the link to pilonidal sinus and PCOS have all been reported. And in conclusion, HS is a heterogeneous disease with involvement of convergent pathway. Syndromic HS has been associated in three main types: structural defect, genetic background, and autoinflammation. And HS is a systemic disease with multiple associations. Thank you.